I am Dr. Jigisha C. Pujara, Professor in Cardiac Anesthesia at UNMICRC Institute of Cardiology and Research Center, Ahmedabad. Today I am going to present about late presentation of transposition of great arteries with intact ventricular septum, issues and anesthetic management. My email ID jigishajayas@yahoo.com. You may communicate me on this email ID. Late TGA with IVS. TGA observed with an incidence rate of 0.2 per 100 live births worldwide. Its asynotic CHD require emergency surgical interventions. Primary arterial switch operation is a gold standard in management of TGA intact ventricular septum. Surgical outcome depends on the timing of the surgery. Arterial switch operation performed within the first 2 to 3 weeks is the ideal surgical approach. ASO allows the restoration of the left ventricle as a systemic chamber and has outstanding short and long-term results. Patient can live the normal life after switch surgery. Late referral TGA are those patients that arrive at repair beyond the 3 weeks of the age and is quite uncommon in the first world. On the contrary, more than 45% of the TGA cases are late presenters in the developing countries. We are also facing the same situation. Many patients coming very late to us with the intact ventricular septum and the transposition of great arteries. Primary ASO in late TGA IVS is repeated in consideration of the involutional process affecting the left ventricle in the subpulmonic position. Such deconditioned regressed LV renders left ventricle incapable of coping with the acute increase in the work of the systemic perfusion after the switch surgery. In most studies, more than 2-month age, increased need for the ECMO or the LVAD. Ideal timing for the ASO is 3rd day of the life is the ideal most as per the research studies. Primary ASO with Class 1B indication for up to 3 weeks with the Class 2A indications for up to the 2 months is per recent guidelines. Two main approaches to manage the deconditioned left ventricle are the hypoxic 2-stage ASO retraining and the normoxic ASO retraining. In case of the hypoxic 2-stage ASO retraining, it consists of a pulmonary artery bending with or without a systemic to pulmonary shunt followed by an ASO when left ventricle reaches adequate mass and function through a hypertrophic process. Indications are more than 3 weeks of the age, absence of the patent ductus arteriosus or presence of the left ventricular outflow obstruction, left ventricle geometry suspected to low ventricular pressure, right to left bulging of the interventricular septum or banana sept LV, index LV mass less than 35 gram per meter square. One should see the left ventricle to right ventricle pressure ratio if it's less than 0.6 in older child more than 3 months or 0.5 in child less than 3 months old requires the 2-stage repair. The normoxic primary ASO retraining, it's performed with the primary ASO and uses systemic arterial resistance to stimulate the left ventricle growth. Postoperative always require the pharmacological supports in the form of the inodilators and inotropes, and some vasopressors are required, and sometimes patient may require the mechanical access device like the ECMO or the LVAD to treat the acute temporary left ventricular failure. Echocardiographic assessment of the left ventricle regression are banana shape left ventricle, here right to left bulging of the interventricular septum, left ventricular mass less than 35 gram per meter square, left ventricular posterior wall thickness at the end diastole at the level of the mitral leaflet tips less than or equal to 3.5 millimeters, septal moment towards the left, D-sept left ventricle, unfavorable left ventricular geometry like lateral and the anteroposterior axis ratio less more than 3, right ventricle to left ventricular mass ratio in apical 4 chamber more than 3. These are the situations where usually LV is regressed. Role of the ballonetral septectomy. Here, as an emergency palliation in children presenting after ductal closure with inadequate oxygen saturation and poor mixing, if the patient is less than 2 months of the age. If child is more than 2 months age, 1.5 to 2 months age, then atrial septum become thick and it is difficult to puncture the atrial septum. So less than 2 months is the ideal. PAS would help buying the time when patient unfit for the surgery, clinically very unstable and severely acidotic patient, patent foramen oval or more than 2 mm but not maintaining the saturation, PDA either absent or 2 mm but not maintaining the saturation in spite of the prostaglandins, and major non-cardiac issues, especially the neurological conditions. Pre-op, if BAS done, ASO to be done within 2 weeks of the septectomy. Preoperative echo to see left ventricular geometry, dimension, shape and wall thickness, interventricular septum motion and position, coronary artery pattern, aortic arch anatomy, ductal size and alveoli obstruction if any present. High risk patients are the patients who are, as per the coronary artery pattern according to the Yacob classification, single coronary artery ostium with the posterior course of the circumflex coronary artery, retropulmonary course of the left coronary artery and the intramural course. The right ventricular to left ventricular diameter ratio more than 3 are again at high risk patient, and absence of the PDA or the small size of the PDA less than 2.5 mm, as a large PDA can cause the pressure volume overload and that is protective. Other surgical options in the regressed left ventricle are left ventricle retraining technique first reported by Yacob et al. In 1977 and Boston group expanded on this approach, followed by rapid two-stage arterial switch in young infants with unprepared left ventricle within 1 week. In two settings of the systemic right ventricle, first in patients with systemic right ventricle failure after and primary atrial switch, that is sending of mustard operation usually during late childhood, and second in the children with the congenitally corrected transposition of great arteries with an unprepared left ventricle before anatomic repair, used in the small children and adolescents. Rapid two-stage arterial switch, innominate artery to right pulmonary artery shunt with tetrafluoroethylene graft of usually 3.5 mm and main pulmonary artery bending with the Marcelin tape. Echo to be seen here, and we have to see the adequate bend gradient around 20. It's a printing mistake, it is around 20. Left ventricle cavity dimensions, we have to see left ventricle posterior wall thickness, we have to see is whether improved or not, and septal thickness and septal movement and the position we have to see in the echo to see the primary first stage repair. Second stage performed as soon as the LV is prepared. Problem with the two-stage repairs are early problems are outcome depends on the size of the shunt, tightness of the band, defining preparedness of the left ventricle, prolonged ICU stay, dealing to the nosocomial infection and the hospital cost. Interval morbidity and mortality definitely increased, and low cardiac output, systemic congestion with severe right ventricular failure during the time between the first and second stage, and may require some ventilatory support and inotropic support to be increased, and it will increase the cost, overall cost and the morbidity and mortality of the patients. Problems due to the shunt, either overflowing or blockage of the shunt, both are harmful. Some late problems are late left ventricle dysfunction due to the increase in the afterload leading to the decreased contractility, neo-aortic regurgitation and right ventricular outflow obstruction. More here, after doing the switch completion, right ventricular outflow obstruction is quite common when two-stage repair has been done. Other surgical options for delayed TGA, Seining or Mustard procedure, also called as the atrial switch. Here indications are satisfactory right ventricle and tricuspid valve function, low birth weight of the patient, late diagnosis, anomalies that prevent the implantation of the coronary artery, and dysplastic pulmonary valve. Again, here problems are increased risk of the atrial arrhythmias due to the sinus node dysfunction, and there are so many incisions are put on the atria. So this leads to the more arrhythmias in this type of the patients. Buffalo obstruction can be there in Senning Mustard procedure, late right ventricular failure, post Senning ASO. Nowadays, very popular when right ventricular fails and medical management ineffective, as increase in the RV pressure, and the RV failure leads to the increase in the morbidity and mortality. So post Senning and Mustard procedure, RV failure, when patient come after some time, maybe little late, again people are trying that do the complete ASO repair, and results are mix and match. Still we have to wait for the results to come. ASO better than the atrial switch because it is in a physiological function. Mental health of the patient is better with the ASO. Self-esteem is also again better, and general health perception would be far better with the ASO rather than the atrial switch. And quality of the life and health status as pursued by the children 11 to 15 years of the old age after the TGA repair is excellent. I said initially also ASO is very promising surgery. If it has been successfully done, patient will live the normal life, patient can run the marathon, and patient can be swimmer or anything. Normal life will be there with this complete ASO repair. But here in the atrial switch, that life is not that much better and somewhat miserable. So now people are trying to do the complete ASO after the some time of the atrial switch surgery. Another novel thing is coming up since a few years are ductal stenting for the retraining of the left ventricle. Here transcatheter stenting of the PDA has emerged as a novel non-surgical alternative option to retrain the left ventricle in the late TGA. It provides pressure and volume overload to the regressed left ventricle, less invasive therapy, a coronary stent, bare metallic stent with a diameter of 4 mm for babies less than 3.5 kg, and 4.5 mm stent for the babies more than 3.5 kg. And if no ductal patency, if duct is totally almost occluded, here then also it is possible by doing the ductal ampulla propped with a 0.014 inch pilot 50 guide wire to gain the entry into the PA through the PDA. And once the LV is prepared, usually within 1 week of doing this, and ASO can be performed when LV regression is reverted. Elian Saraf from the France wrote in his editorial article about his experience of the ASO in more than 45 days child. He and his team observed 25 days to 170 days children. Left ventricular mass more than 3.5 gram per meter square versus when between the 25 to 35 gram per meter square. ASO was on base of the LV mass to end diastolic left ventricular volume ratio if more than 1.2 ASO, and if it is below these, then rapid two-stage approach favored. Median interim duration was 8 days. Anesthesia consideration in ASO for the late TGA ventricular septum. These patients are very risky. We have to be very vigilant. Monitoring has to be very vigilant, and pre-operative preparation, anesthesia care, monitoring, post-operative care, all require the tremendous effort of the whole team of the surgery, cardiac anesthesia, intensive care unit, pediatric intensive care people. All these can lead to the successful management of this late ASO in the TG-IVS patients. Standard anesthesia and surgical care technique, we may use the MADAS, fentanyl, vecuronium. Patients should be NPO for 4 to 5 hours. Vigilant monitoring, including the NIRS monitoring, here is nowadays coming up, and most of the tertiary care centers are using the NIRS monitoring to see the mixed venous saturation and cerebral perfusion. Maintenance of the volume, maintenance volume should be 6 to 8 ml per kg. It should be restricted, not to overload and not to underfill. We have to do this T for these and avoid the fluid overload. Radial or femoral artery cannulation as per the institute protocol and what we get in the particular patient. Right IJV cannulation. Avoid the arterial puncture. Here is quite essential, as you know, because the surgery is on the aorta, and if arterial puncture has been occurred, then hematoma chances are there and difficulty in the anastomosis. All patients has to be given 10-hexamic acid before skin incision 10 mg per kg, after coming of bypass 10 mg per kg IV, and in the ICU 2 mg per kg per hour for first 5 to 6 hours in the ICU. Neonatal T probe, if available, is best. We have to use, otherwise epicardial echocardiography required post bypass. CPB management. Moderate hypothermic CPB is fine. Nowadays we don't use the phenoxybenzamide, but if used, some places are still using, but with levosimendan and milrinone, we have now stopped using phenoxybenzamide, not much required, so we have stopped using, but some centers are using it. We were also using, and it's quite okay to use these drugs. If it used, dose would be 0.5 to 1 mg per kg infused slowly just before aortic cannulation. In maintenance, if required, 0.3 to 0.5 mg per kg 8 hourly or 0.5 mg per 24 hours in the ICU. Borderline or regressed left ventricle mechanical support with the ECMO or LVAD may require. Integrated ECMO CPB circuit patients shifted in the ICU and can be started when required. So some centers are very much accustomed with the integrated ECMO CPB circuit, and the benefit is decannulation mostly within 12 hours to 24 hours possible, and if at all required ECMO, it can be established easily and immediately, and infection chances are less because we in a hurry sometimes we may not taking care of the infection precaution. It reduces the cost, crisis of instituting ECMO, and significantly reduce the infection. Cardioplegia, single dose cold crystalloid cardioplegia, custodial is some places they are using these, and it's to be suctioned outside the heart from the coronary sinus. Some centers are using Delnido, it's also again fine, but nowadays people as afraid of Delnido, and some centers, not all centers, because they are having trouble with the myocardial protection with the Delnido, so they would stop using, but some centers are using with very happy with this Delnido also. So single shot 30 ml per kg can work for 90 minutes, and if second dose required, St. Thomas cardioplegia given after aorta closed by root, and the aortic bleeding can also be checked simultaneously while giving the St. Thomas cardioplegia. CPB blood gas maintenance with the alpha stat only. We don't use the PS stat. Some centers are still using PS stat, but there are again some problem with the PS stat, so most of the centers are stopped. Cuff used routinely as per volume optimization in the hematocrit. 35% hematocrit to be managed during the bypass time, and at the time of the rewarming around 40% hematocrit has to be maintained. MOF, as well as modified ultrafiltration is done some places, and some centers have stopped using MOF because now perfusion technology is nicely good, and patient managed very nicely during the on bypass, so hematocrit also managed, so MOF may not be required, but sometimes when patient is in the trouble, even zero balance ultrafiltration also recommended and required. We use the plasma light and albumin for the Z-buff, and my personal experience, I had twice used the JAF in my neonatal patients, not in the TJ, but some other case like truncus arteriosus with arch, and we were very happy with using the Z-buff, and patient came out nicely after 2-3 management, not only the Z-buff, but 2-3 management we come out nicely with the come off the bypass and win the CPB with all these maneuvers. So Z-buff is quite promising. Pump prime with the Paxil volume and albumin or the FFE 10 ml per 100 ml prime. Usually Lasix has been given 1 mg per kg after sternotomy to be given after sternotomy is that if effect of Lasix causes some hypokalemia, then at least sternum has been opened. So delivering of the shock, if patient at all develop VT or VF, we can give the shock. And once we have our ABG in our hand, we may rectify the electrolytes by checking ABG. So Lasix has to be given ideally after sternotomy, not the before sternotomy. Sodium nitroprusside has to be used liberally during the bypass. It will nicely keep the patient dilated, and coming of bypass is easy. Urine output will be better with this. Weaning from the and of course on CPB pressure has to be maintained around 40 millimeter Hg in neonates. Weaning from the CPB, T for the dearring and see the cardiac function, particularly left ventricular function, left ventricular cavity, whether it's dilated or not, regional wall motion abnormality, and anastomosis of the aorta and the pulmonary arteries. We can see any new development of the mitral regurgitation. We can see inotropes used are the milrinone. Our practice normally in such type of the patient is loading the milrinone 50 mics per kg over 10 minutes, followed by 0.5 mics per kg per minute, and adrenaline as per the requirement 0.05 to 0.1 mics per kg. These patients are very sick. Usually they require inotrope and inodilators, and if patient is difficult to wean, then injection levosimendan, again promising drug, 10 mics per kg over 10 minute bolus. If levosimendan has to be given, it has to be given bolus, then it will give immediate effect. Otherwise, if we start just maintenance, we don't get immediate effect of the levosimendan, and levosimendan has to be given over bolus dose over 10 minutes, followed by 0.05 to 0.1 mics per kg per minute. If severe LV dysfunction and difficult to wean, here levosimendan when we give, many people are asking all these inodilator when we use hypotension chances are there. My personal experience is like that, if we use the levosimendan in such type of the patient when LV is severely dysfunctional and difficult to wean, levosimendan definitely improve the contractility of the left ventricle and will increase the pressure only. Immediately it will increase the pressure, and once levosimendan loading has been finished, if we give the calcium, is a calcium sensitizer drug, so when we give the levosimendan, we have to give the calcium 1 ml per kg bolus. Very slowly we have to give the levosimendan. After levosimendan, 1 shot of the calcium 1 ml per kg, and this will improve the pressure. Of course, when we use the loading dose of the levosimendan, maintenance dose of the milrinone should be reduced to some 0.35 mics rather than giving the 0.5 mics. If milrinone at all use alone, we can increase the milrinone dose to 0.75, and milrinone loading sometimes 75 mics to 100 mics per kg will also give beneficial to the contractility of the left ventricle. So there are so many approach, different approach at different places as per our convenient and our knowledge and our experience we can use. And if at all not weaning possible, then ECMO or LVAD to be used as and when required. If left atrial line has been, our practice is not to put the LAL line because of the infection and bleeding issue, but some places are still using the LAL line because of the easy availability of the echocardiography. We are not using a neonatal T-probe available at my place, so we are using the TE, but of course some LA line can be used. It will be helpful to measure the LA pressure, and LA pressure should be in the single digit, less than the 10 millimeter Hg. When weaning from the CPB difficult, see for the warning signs which suggest the patient may require some mechanical supports. These warning signs are inABG lactate is increasing trend, desaturation in spite of the increasing the FiO2, LA pressure rising trends in more than 10, echo showing the dilated left ventricle with the severe dysfunction. Some MR may be there due to severe LV dysfunction, airway pressure increase, unstable hemodynamics, and not improving with all the pharmacological support, then of course requires some mechanical support. Weaning trial twice or thrice fails, then we may twice failed, then we may think of the ECMO or the, if available, LVAD. Post-operative management, always peritoneal dialysis catheter inserted in the OR. We have practiced to insert the PD catheter in the OT only. chest to be kept open if hemodynamics are not maintained. Higher PEEP may be required as there is a severe LV dysfunction. Here role of the PEEP is more. If is desaturation, we have to increase the PEEP to 5, 6, 7 as required. Elective peritoneal dialysis to be started in the PICU. We don't give the diuretics in the ICU without seeing the renal function test next day. So we electively start the PD in the ICUs. I have personal experience. I had used the PD even in the theater also, one cycle given, and it gave benefit to the patient. So after seeing next day the renal function, if renal functions are normal, then we use the bolus Lasix, and if it gives response, we start the infusion of the furosemide. But if renal function altered, then we continue to manage the patient with the peritoneal dialysis. We try to make the patient negative as far possible. Elective ventilation until the hemodynamic stable or chest close. Post-op problems, primary LV failure, sepsis, and surgical problems like intra-op coronary injury and some kinking of the coronary is normally ASO patient surgery can have this type of the complication are all common. Main thing is LV failure and LV dysfunction. Late TGA and the LVAD, left ventricular assist device generally required in older children, but sometimes in the neonates also with the unfavorable left ventricular geometry. So it's not like late presentation patient having the LV dysfunction only, but sometimes it's happen that early presentation also 1, 2, 3, 4, 5 days patient also have the severe LV dysfunction. So unfavorable LV geometry, regress LV requires sometimes LVAD. Whatever the age of the patients. LVAD decision based on no LVAD if echo is normal or mild LV dysfunction, non-dilated left ventricular cavity, LV pressure within limits. So within single digits LV pressure. All these patients LVAD not to be used, only LVAD to be used when these all are unfavorable. All pharmacological management has to be managed started first and tried hard for managing the patient with all pharmacological measures, see the T, understand the problems and manage the problem rather than using the mechanical device early. So we have to think, because all these having is their own complication and cost is of course there. And if they don't work, then and then only LVAD or ECMO has to be planned. Fluid with the target to LA pressure less than 10 and maintaining the systemic perfusion pressure to produce the adequate urine output and maintain low lactate and the warm extremities. Children required LVAD with more than moderate left ventricular dysfunction with dilated LV cavity and weaning from the CPB phase 2-3 times, then requires some mechanical support. Main problem occur in the TGA patients, not the late TGA intake VSD, but all the switch surgery. Bleeding is an issue, and most of the time after coming off bypass, we are giving some products like cryoprecipitate or the platelets, or some people are giving FFP blood. All these are giving the more volume load to the left ventricle, which is already weak. Left ventricle function is already low, and if we infuse the more volume, rather transfuse the more blood and blood product, that is very deleterious effect and harmful for the patient. So my practice is we start managing the patients since beginning. Fluid restriction during the CPB, ultrafiltration, conventional ultrafiltration, and we try to make the patient negative balance, hematocrit best. Post bypass, if 40 hematocrit is there, then no need to transfuse more amount of the blood at a time. Rather than we just give the 1 unit of the cryoprecipitates very slowly over a period of 10 minutes, that is 15 to 20 ml, 2 ml, 4 ml increment we give. And then we start the infusion platelet from the infusion say pump. So 50 ml per hour also you can give, 30 to 50 ml per hour if you give slowly, then it will not much harm to your patients. So volume restriction is mandatory in such type of the patient. And we see if we maintain the hematocrit, blood is whatever the required is per the hematocrit, the slow transfusion of the blood is then done. If hematocrit is by chance low, patient is losing the blood due to some bleeding issue, surgical bleeding issue, then Before giving the platelet, you have to give the blood. So hematocrit if better, then it will be helpful in the hemostasis also. So try to maintain the hematocrit, and volume loading should be very gradual and very restricted rather. LVAD require fewer resources and less monitoring. Overall cost reduced, heparin requirement less, so less bleeding complications and better LV support with the LVAD. But cost is of course the thing. Weaning LVAD, and if LVAD should be available at the center. Weaning of the LVAD around requires 7 days when left ventricle contractility and pulsatility in the arterial pressure tracing improved and the levosimendan infusion has been started before weaning of the LVAD. LVAD wean and decannulation done then. LV shape and geometry restored usually within 1 to 6 months when we see the patient in the follow-up. Usually more than 1.5 months required with the long or maybe more longer time duration in the older children. But after 1.5 months remodeling of the LV started, and usually within 3 to 6 months we see the LV contractility has been improved in case of the immediate severe LV dysfunction also. To conclude, primary ASO can be done safely in children beyond the neonatal age group. The boundaries of 2 to 4 weeks are now taken to more than 6 weeks and might be pushed further. Unfavorable left ventricle geometry, which was considered to be a contraindication for the primary ASO, is a transient change and can be successfully managed with the pharmacological measures as well as mechanical devices like ECMO or the LVAD. A change in the left ventricular shape is due to the low afterload and not the intrinsic change in the left ventricular myocardial properties. So patient can regress LV also. Patient behave nicely many times after the surgery without any mechanical support also. Long-term follow-up of these children will give us more answers, but early results are encouraging, and we believe it may be appropriate to cautiously extend the age limit for the primary ASO in infants with DTGA with IVS beyond the age of 6 weeks. Thank you.